Good afternoon, everybody. We should be starting here in just a few minutes. If you are a committee member, if you would, please put your name in the chat. Looks like nobody's on the call. Please put your name in the chat. I was just checking if we had anybody call in. It looks like not yet, but we should be starting here in just a few minutes.
Hi, Sharon. I'm here too.
Hi, Jesse. Welcome.
Sharon, will you give me a heads up when we're nearing a quorum, or we're probably almost there?
So, yeah, I can. Since we do not have the January MAC minutes today, so we won't have anything to vote on. So we don't necessarily need the quorum. I will mention that somebody did put a question in the chat early on before we got started, and I can read that because I don't think if you join after they put that in the chat that you can see it. So I can read it once we get to the committee member updates.
Okay, that'd be great.
So,
all right.
You can go ahead and get started. Thanks, Jesse.
Okay, great. Well, I see people are still trickling in, but let's just go ahead and my computer is suddenly exploding. Great. Well, welcome everybody to the March Medicaid Advisory Committee, Medical Care Advisory Committee. Happy March, everybody. Happy St. Patrick's Day, I guess, if anybody said. I'm wearing green because I have young kids and the pinching gets old fast, but I hope everybody is having a great day, and we made it through the session, so here we are. Let's see, we're going to get started I want to give a quick announcement that we typically do at the beginning of these meetings, that this is a public meeting, so members of the public are welcome to ask questions, throw questions in the chat, feel free to contribute, raise your hand, or just come off mute. This is meant to be a meeting where everybody can participate and contribute. And it's also a virtual meeting, as you've noticed. We have made the decision as an executive committee to continue to hold these meetings virtually until further notice. With that, we don't need to approve the minutes since we don't have January meeting minutes at this time. So I'll just move on to our quick update about our meeting with the managed care or ACO plans about building vaccine confidence among Medicaid members and vaccine outreach. And if you were not able to attend but would like to attend future meetings to discuss this, we left this meeting realizing there's a lot to discuss. It's just the start. So please let me know if you want to put your name in the chat if you'd like to attend future meetings to talk about the role that the managed care plans are doing and can be doing to increase vaccine outreach. I guess in terms of where we left this meeting, Brian Munson from Molina is going to be coordinating with some of the other ACOs to look at the ongoing work that they have been doing and assess what was most effective and where they really saw the most impact, and then coming back with that information to the full group. And then we will continue to meet with that sort of evaluation framework or a better understanding of what activities have been most effective. And we only heard from about 2 plans. We actually ran out of time, so we'll probably hope to hear from other plans and the work that they're doing in the future. So that's a quick update. For those of you who are there, if there's anything else you'd like to add about that meeting, please feel free. Okay, great. Well, moving on to committee member updates. This is the time where we have an opportunity for any committee members to share updates or news, questions, concerns, just share what you're working on or things that you'd like to flag for Medicaid department or for other participants on this call. And Sharon, I know you said you have one already.
Yes. So Bill Tibbetts put in the chat if we have received any feedback from the federal government about the waiver to provide tenancy-based services to help people avoid returning to homelessness. And so I don't know if there's anyone from DOH who can speak to that. That's on the call.
Sharon, I don't know if there's anyone on that can give a response to that right now. Let's loop back to that if we could, please.
Jen, this is Laura. I can
Thank you, Laura.
yeah, I can quickly, sorry, I didn't know if you wanted to respond. We did receive approval from CMS on March 4th. And so we are currently in the process of developing the programming, and we expect to have, we're targeting for implementation this fall. But again, we're still, that's still in the works, and we can continue to keep the group updated as we progress.
Bill, do you have any other follow-up questions about that if you want to ask them?
Will there be some sort of public rulemaking process? I'm just interested.
Yes, we do. That will be part of the development, the rule, the policy. So that is all part of the process, yes.
Great, I look forward to it.
Thanks, Bill. Any other updates, either from committee members or anyone else on this call that has questions or like to share anything, any events? Just a few moments for an open forum. Great. Okay. Actually, I have one thing I can mention briefly. It came up at the Utah Oral Health Coalition on Friday. If you weren't there, and I'm sure we'll actually talk about other items, but we did recently learn that the state dental director, Dr. Kim Mickelson, has been with the state for a long time, is stepping down. And I don't know what next steps are, but I think that will be a pretty dramatic change for just the state oral health program. And so excited to hear about that. And I'm sure there'll be more updates as we learn them, but I just wanted to let everybody know that there's going to be some changes at the state oral health program. And we also have, I'm going to put in the chat some oral health resources that came up during the Oral Health Coalition meeting too. I think it's easy to forget that there is an ongoing list of low cost and free oral health or dental care resources available. So I'll put those in the chat if anybody would find them useful to share with people. Okay. Anyone else? All right. Jennifer, the time is up. Just a minute time. Stephanie put in the chat, will there be an evaluation from DOH or the U on how the change to oral health has been impacting members? Do you mean with the U, Stephanie, or which change? Or all of them? Okay, yes. Jennifer, that's probably good, or you might know, yeah.
Yeah, certainly. I'm happy to speak to that. I know there are components of the program that is the University of Utah School of Dentistry and the provider network that they're managing for the adult Medicaid population, those different populations. They are evaluating various metrics, yes, and they will be looking at those. I know they're gathering data, and we've spoken with them about a variety of things that they're looking at, and so I know that's something that they are doing.
Okay, terrific. Well, maybe as we learn more about the dental director position too, that's something we can continue to talk about in future meetings. But with that, Jen, I'll send it over to you. Yeah, I agree, Stephanie. It'd be great to know what happens next. All right, and if you want to, the time is yours for legislative updates.
Yeah, certainly. Okay, I'm going to share my screen. So Sharon, if you don't mind, I will assume the screen here. Thank you for the opportunity to go through some legislative updates with you today. It's been a busy session. There were more than 400 different bills that were reviewed by the department, and we're happy to go through various items with you today. Our presentation is going to look at 3 different parts. The first piece is going to look at the funding that was approved from the governor's budget and the appropriations subcommittee. Next, we're going to take a look at various bills and the different components of them that were approved. And then the third piece that we're going to look at is going to address bills that did not receive that did not pass this year. So I'm going to also note from the start that I'm going to be covering some legislative updates and the various components from, and then Eric will be covering some of the funding pieces from the session. So if you can hold your questions around the funding and the allocated resources that have been put to that, you can hold till Eric's portion. But I'm going to be covering these pieces first. So they do kind of go hand in hand with each other. With that, I'll go ahead and begin. So House Bill 2 noted Medicaid funding items that were approved from the governor's budget and the Social Services Appropriations Subcommittee. And there are several of these we'd like to highlight. And first is one that many of these we've mentioned before, but the first is coverage for dental crowns, which are a permanent crown placement for individuals, as well as resin composite fillings for pregnant women and children. The second item is increased reimbursement for MAT, or medication assisted treatment for substance use disorder. And MAT is the medicine as well as the counseling service, and that's reimbursed in a bundled rate today. And so there was additional funding to increase the reimbursement rate for that. A new service was funded called Medication Therapy Management. This is a pharmacy-run service which identifies high-risk Medicaid members that have chronic conditions, and it reimburses for an annual consultation done directly from the pharmacist to the member for this service. There was also funding put forth for equal Medicaid reimbursement rates for autism. And this is meant to accomplish 2 things. First, it's going to increase the reimbursement rate for ABA providers compared to their other peer professionals. And then the second thing is it's meant to address access to care for medically necessary ABA services. We have ongoing funding that was approved for our PRISM system, our maintenance of the Medicaid Information Management System. So that is our system-wide software that the Medicaid system runs off of, that our PRISM project that will go live in January. We also have approved funding for alignment of behavioral health service codes for Medicaid reimbursement, and this is around the residential treatment rates. Also have funding for long-term services and support for behaviorally complex individuals, and what this was meant to close the gap on individuals who have behavioral complex needs, and as they're being discharged from an inpatient stay, being able to have a facility that can support the complexity of care for 50 behaviorally complex individuals at a nursing facility. There's also funding appropriated for a Medicaid ACO rate increase. Were there any specific questions about these items from House Bill 2 and the specific funding here? Okay. We'll move forward into the second section, which are looking at some specific bills, and we'd like to take the time to go through some of the elements of these bills with you. And the first item we'd like to look at is House Bill 236, Behavioral Health Amendments from Representative Elison. And this is proposed that in July 1st of 2022, the department will solicit applications from primary healthcare practices to implement a collaborative care model, which will look at an integrated physical and behavioral health service within this primary healthcare practice. With this, these applicants will actually apply for a grant, and the specific use of this grant will be to hire and train staff that would administer the program. It would help identify and formalize the contractual arrangements with different mental health care professionals or case managers that would help bring these two services together and be used to implement the program. Or the funds can be used to purchase or upgrade software or other resources. The department will look at grant applications that are received and select up to 6 grants. So from 1 to 6 grants can be awarded. Grant applicants, so those who are interested in putting forth an application, need to satisfy various components in their application. The first will be to describe the target population and really describe how the target population would benefit from this integrated care model. They also need to describe how the existing or planned services would support an integrated delivery model in this program, and then an explanation and just a description of how the data would be collected and would be provided to the department. For July 1st of 2023, the department will report on those different primary care sites that were funded to receive these grants. And also, the following year, the department will submit a report to the Health and Human Services Interim Committee with a summary of the first year, which will be looking at the data that's been gathered and knowledge gained in providing grants in this new integrated behavioral and physical health service model. The second item of this bill also looked at some funding, and it actually fixed language that passed last year that will align the funding for behavioral health services within Medicaid with the physical health services by helping with providing similar increases that are received by the ACOs to those also be applied to behavioral health services. Any questions on this bill? Okay. The next bill we'll look at is House Bill 413, Medicaid Amendments by Representative Dunnigan. In this, by May 31st of this year, the department will establish a behavioral health delivery working group. And the bill specifically describes who will be in this working group. It will consist of at least 16 individuals with representation from various providers, and it specifies local mental health authorities, behavioral health organization, policymakers, the accountable care organization. This working group will convene and recommend to the department metrics for the delivery of behavioral health services through managed care, specifically how physical and behavioral health services can be integrated for the TAM or targeted adult Medicaid population. This group will also recommend ways to improve the delivery of behavioral health care services to enrollees and have wraparound service coverage for enrollees who need specific non-clinical services. By July 1st, 2023, the department may enroll TAM members in a managed care and integrate the delivery of both behavioral and physical health services in certain counties. And then this is conditional upon the department seeking input from individuals who qualify for TAM, various county officials, managed care organizations, and providers, and the department's determination that the metrics established by the working group are met. So we are in the process now of getting our internal work together to establish the behavioral health working group, and then we'll start our next steps in convening our larger group with the targeted members. The third bill we'll present is the Diabetes Prevention Program put forth by Representative Harrison. In this, by July 1st of 2022, this authorizes the Medicaid program to reimburse a provider for diabetes prevention services for those individuals who are diagnosed with pre-diabetes, and they will use the components of the National Diabetes Prevention Program. This bill did include a reporting requirement with the expectation that it was effective and that fewer individuals with prediabetes will receive a diabetes diagnosis. This does have a termination date of 2027, but the legislation may review it before the termination date to look at the effectiveness of the program. And I think this is set to enroll about 500 applicants, 500 individuals annually. Okay, House Bill 200 is the Medicaid waiver for medically complex children, put forth by Representative Ellison. And in this does expand the eligibility and coverage for individuals in the medically complex children's waiver. Currently, there are about 575 individuals enrolled, and this bill allows 130 additional children to be enrolled in the program. This also changes the open enrollment period from what was an annual enrollment period to a rolling enrollment period for children who are on the waiting list. The next item is Senate Bill 41, Behavioral Health Services Amendments, put forth by Senator Kennedy. This will be effective July 1st of 2022, and it establishes another integrated behavioral health care grant program. So this is a little different in that this particular bill establishes that the department will issue an RFP, and it's directed at local mental health authorities to develop or expand a project to provide effective delivery of integrated care. With this RFP, an applicant, a local mental health authority applicant, will describe its operational plan and its contracts and partners to implement this proposed project. The department has flexibility again on how the payments may happen, but initially the grant will be funded with state-only funds. And the bill also contained language that by December 31st of 2022, the department would apply for a waiver or state plan amendment for federal financial participation in this program. Senate Bill 45, the Department of Health and Human Services Amendments by Senator Andrade, formalizes our consolidation of the Department of Health and Human Services that began last session in last general session. This officially merges the Division of Substance Use and Mental Health with Medicaid to become the Division of Integrated Healthcare. Were there any questions or comments, thoughts on the bills that were presented?
I'm just wondering for Representative Ellison's bill for the medically complex children's waiver, do you know how many children were initially going to, I think that the funding was reduced, right? Do you know how many were initially going to be covered by the funding?
Go ahead, Tanya.
Maybe you already know the answer, Jim, but it was about 300, Jesse. So it ended up getting cut in half.
Thanks.
So Stephanie, you had a question asking if there was intent language with appropriations that impacted you all that you're paying attention to. And yes, there is intent language. We are still gathering all of our post-session materials together, looking at the different funding as well as the different bills and appropriations that were received and putting those all together. If that's something of interest, we can bring some of that back to you as well. Unless others want to comment on some of that now, specifically. Okay. Thanks, Stephanie. Okay. If there are any other questions, feel free to raise your hand and we can certainly take those questions. The last area that we wanted to touch on were bills of interest to Medicaid that did not pass in this session. And there are several listed here, but I'll go through them one by one. The first is House Bill 247, the Child Health Care Coverage Amendments. And this bill looked at providing a continuous 12-month eligibility for children. And we also want to note that the continuous eligibility for children was also part of the governor's budget, but it did not end up getting funded this year. House Bill 220 was another continuous eligibility that looked at extending postpartum coverage from 2 months up to 12 months for individuals who had postpartum or pregnancy coverage. The third item was House Bill 212, healthcare coverage amendments that would create a new Medicaid program for wraparound coverage for individuals with disabilities. Senate Bill 105, family planning service amendments, were to establish a family planning waiver for individuals below 250% of the federal poverty limit. Senate Bill 185, children's health coverage amendments, was to extend Medicaid and CHIP coverage for children. House Bill 365, telehealth amendments, was to update our telehealth definitions, including which drugs may be prescribed through asynchronous telehealth. Senate Bill 230, preventative primary care pilot program, was creating a pilot program focused on preventive care in one county. And then the last item on the list is our autism coverage amendment, Senate Bill 241, which looked to extend autism treatment services to Medicaid adults. So with that, that is the summary of my presentation on legislative updates. Are there any remaining questions or comments that we could take for this item? Sure. Happy to share the document, Jesse. Also note that we are, again, working within our teams to get working on these various bills. There's a lot to do, and we'll bring updates to you as we develop our work groups and put forth the different items around our rules and SPAs and our waivers for these items, and we'll bring them back to you for updates. Thank you for the time. So
Thanks. That was really helpful. And thanks for sharing that too. Right. Well, then I think with that, unless there are any other questions, thoughts, rants about any of the bills that that passed or didn't pass. Okay, great. Then Eric, it's over to you.
Okay, great. And Sharon, I'm going to take over and present again. So, or not again, but present. And Jesse, I will share this with everybody after. So you're aware. Okay, let's wait and see. Can everybody see that?
We can see it.
All right, great. Okay, so let's talk about what was funded and how much was funded. So I'll go through a lot of the bills that Jen mentioned. So for state fiscal year 2022, we received a supplemental appropriation due to Medicaid consensus. And this was largely because when we initially did Medicaid consensus in state fiscal year 2021 for state fiscal year 2022, we weren't certain how long the public health emergency was going to continue for. And so we had to update those assumptions and change the amount of general fund funding that was needed. And so you can see it was a reduction in general fund and an increase in federal funds to show that the public health emergency continued. So that's pretty much all that happened in the current year. So moving on to 2023, Jen touched on a lot of these. These just show the amounts that were funded. So the first item was part of House Bill 2, I believe, or 2 or 3. I can't recall which one off the top of my head. But it was for better materials for Medicaid dental crowns and fillings. And you can see they gave us $140,500 general fund with matching federal funds, we get a total of $444,700. The next item was long-term services and supports for behaviorally complex individuals. This is coverage for about 50 behaviorally complex Medicaid members in a nursing facility setting. And as you can see, they give us $134,100 general fund with some other funds that are negative, and along with the federal funds for a total of $412,700. Next, we'll go to House Bill 413, which is the Medicaid amendments, which increase the reimbursement rate for residential treatment for substance abuse and mental health. Now, this one is kind of interesting because between these two funding items, there's $436,000 general fund that's appropriated to Medicaid, which will be distributed to the counties to use as match to actually fund the increase in residential treatment services. So that second line shows how all the funding broke out, and you can see there was the general fund, there was the expansion fund funding to cover those in Medicaid expansion. The 436 that will be transferred back to the counties is to cover those people that are in not Medicaid expansion but regular Medicaid. Next, we had the equal Medicaid reimbursement rate for autism. We were funded $3 million general fund with matching federal funds for a total of $8.8 million. Next up, we had the Medicaid ACO, or Accountable Care Organization, rate increase, where we were funded $2.8 million in general fund and $340,000 from expansion funds. And when combined with federal funds, we get $11.8 million. Next, we have medication therapy management, which, as it states, allows pharmacists to perform medication therapy management for Medicaid members. We received $136,000 general fund with matching a little bit of expansion fund and with federal funds for a total of $581,000. Next, we have Senate Bill 41, Behavioral Health Service Amendments, which Jen touched on this a lot better, so I won't describe what it's doing, but the general fund amount was $200,000. Next, we had the House Bill 80 Diabetes Prevention Program, which is coverage for the National Diabetes Prevention Program services within Medicaid. We received $89,800 in general fund with $6,000 expansion funds combined with federal funds for a grand total of $325,000. Next, we have the House Bill 200, which is the Medically Complex Children's Waiver, which opened those 130 new slots. We received $929,000 general fund, $180,000 in other funds, and with combined federal funds for a grand total of $3.2 million. And finally, we have Medicaid consensus for state fiscal year 2023. Now, when we did consensus, we were still under the assumption that the public health emergency was slated to end in April. It's been extended into July. So these numbers are based on receiving the enhanced federal match through the end of June and not receiving any in state fiscal year 2023. Michael, go ahead.
So I don't think it's been extended yet, but I think with the public health emergency through the middle of March, you get enhanced funding through the end of June, which you didn't know in your consensus in November. So this reflects the enhanced match through June, I believe, because the public health emergency as yet has not been extended officially. We just know they haven't given us the 60 days notice that it will be ending.
Right. And so we have a strong indication that it will be going into July and will probably continue. The match will probably continue through September. So we will take care of that in the October consensus if they do extend it.
So they made assumptions that the first quarter of fiscal year 20, okay. So
No,
it's just,
we did not, but we have a strong indication that that will be the case. So we will probably have to revise all these numbers in October.
fair enough. But yeah, for the current fiscal year appropriations, it's because the public health emergency is through the middle of April,
Right.
with the enhanced match through the end of June. Okay.
Yep, you're correct.
And then I have another question. I know you're on a roll and moving
No, it's okay.
very eloquently, but if you could go back to the ACO funding amount, I think you said 2.8 some million dollars.
Yes. There it is. Yep.
All right. So this is in addition to what was in the consensus for
Correct.
the 2%, but
Correct.
it does not include the additional $1 million that was directed and transferred from an additional different subcommittee. Is that right?
So we are actually still trying to find that. I haven't been able to isolate that particular funding. Emma and I were both kind of scratching our heads on that one and looking for it. So we're still trying to dig through it, but this is what we know for sure as of right now.
Okay, well, if you need some help, there are many of us who would be happy to help you find that. But
Certainly,
okay,
that would
this
be-
was explicitly appropriated in House Bill 2 that you can walk through the crosswalk
Right.
on the index from EAC. But you're
Yep.
saying from the motion sheet, shouldn't Russell just be able to tell you where that is hidden in the morass of all of the bills?
Yes, he's been out of town. He just barely got back Monday, so I haven't had a chance to connect with him to figure all that
Okay.
out.
You need
Fair
the
enough.
ticket?
Sorry. Jesse, do you have a question?
Yeah, I'm just wondering what this, Michael mentioned, well, what, if you could explain what the additional $1 million is, I think I missed that.
Yeah, so they had a list of appropriations that is pretty easy to track coming out of EAC, but in the motions, there was a transfer of $1 million from one of the other subcommittees into the Social Services Subcommittee directed to the ACOs. So I was just trying to make sure we've kept track of that, but as Eric's mentioning, okay, it's not as easy to follow in terms of its origins. So I guess we'll just need some additional clarity there.
So on top of consensus, then there's now, it should be about 3.8 million is what you're saying, potentially.
$3.8 million of general fund is the assumption. So it's roughly a 3.35% increase is what we were tracking coming out of the session.
Do you know who made that request? The additional $1 million? Maybe if you're able to say. No. All right.
Yep. All I know, Michael, is in combing through the crosswalk that Russell sends over, it shows our line item and all the appropriations.
Sure.
If it's in there, it's buried under something else that we haven't been able to untangle yet.
Yeah, I mean, just recognizing they list the appropriated items and then they crosswalk it to the bill, but motions like that don't fall into the crosswalk. So I think that it should be fairly easily reconciled, but you don't have the magic Rosetta Stone to get you from point A to point Q.
That's right. Yeah.
All right.
So working through that, hopefully we'll have that all settled in the next couple of days. So.
All right. Thank you.
All right. So back to where we were. So one thing I was asked to do was to talk a little bit about the Medicaid consensus process to kind of, explain how it works. So basically what we do is we divide the program into some high-level eligibility categories, and I'm displaying those on the screen. So we divide it into adults, adult parent caretaker relatives, aged, blind disabled, child, pregnant, and QMB, which is qualified Medicare beneficiary. Then on the expansion side, we do parents less than 100% of the FPL, childless adults less than 100% of the FPL, parents over 100% FPL, and childless adults. Sorry, that should be over 100% FPL. I apologize about the mistake. I will correct that before I send it out. Then here are the steps that we take with those categories. The first thing we do is we take our costs from the prior year and determine a per member per month cost for each of those categories. So we look at the costs, divide it up by those categories, and come up with a per member per month cost. We then work with the LFA and the Governor's Office of Planning and Budget to each independently project what we think enrollment is going to be like for each of those categories. We then sit down in a meeting and come to a consensus agreement on what that enrollment is going to be. Now, what that entails is we will look at the assumptions that we made in our projection models and the assumptions they made and try to use the best set of assumptions. Now, sometimes we can't agree on what the best set of assumptions are because, everybody has strong opinions on how things are going to go and what economic factors are going to control this. And so if we can't come to a consensus on what factors are driving it, we typically will just take an average of the 3 projections. And so we call that our consensus enrollment. And then based on that, we take the per member per month we calculated from the prior year, multiply it by that consensus enrollment, and establish a base amount that we're going to be funded. Now, after we've established that base, we have to make certain adjustments because we know that we have to adjust for any new funding that's coming in, any statutory changes, the federal match rate, or the FMAP, that comes from the federal government, that is CMS's share of paying for the Medicaid program, changes on an annual basis. So every year we either have to increase or decrease funding based on how the FMAP is moving. And then finally, we incorporate some inflation adjustments to it to make sure that the funding is adequate. And so that's really at a very high level how the consensus process works. Any questions? Stephanie.
Thanks. Can you back up one slide? I just have a question about, thank you. Okay, so use last year's cost based on, okay, so how do you factor in utilization? Because costs are like made up within the healthcare system. So how do you how does that kind of play into this? And like, what is the, how do you look at utilization and then quality metrics? Does that have anything to do with the PM, or what's the process for determining that PM?
So with the PM, we're just trying to get a baseline of what it costs for this type of member. Utilization is kind of a tricky thing to get worked in there because utilization is going to vary from person to person. And so kind of our hope and anticipation is on such a large volume of people that will kind of be evened out through the law of averages by having such a large pool of people. So we don't really make any adjustments for utilization unless it's something very specific that we know, like I mentioned in the next slide about statutory changes. If we know that something is going to change coverage and more people are going to utilize a service, we'll make an adjustment after we've established that base. Emma.
Yeah, and I was just going to comment, Eric, that the per member per month is really a combination of the cost and utilization, because it basically is, a reflection of how much people utilized Medicaid in the previous year. So it doesn't account for maybe changes in utilization that are upcoming, but that happens at the end where, the group discusses what's changing in terms of policy. Are we expecting to see higher costs in pharmacy? Are there any other major program changes that we're aware of that get discussed with the LFA and GOPB and are taken into consideration?
Okay, thanks for that. So then so how does the whole part of there's some of the conversation is about how much risk are the plans willing to take on, and then they can because that's kind of a part of why it moved into this direction as well. So is that not a part of the PM is not they don't really factor that into this conversation?
Yeah, so think of this as bigger than the plans. This is the entire Medicaid program. So not only would it include the plans, it would include all of fee-for-service and everything that Medicaid does. So this would include the HCBS waivers, which aren't governed by the plans. And so this is looking at it at a much larger scale than just the plans.
Okay, thanks. And sorry, one more question, because I just want to make sure I understand this. So and I realize it's an aggregate, and so I don't know, maybe you would hope that things average out, but there are these weird situations where one hospital will charge $75,000 for something that another hospital would charge $9,000 for. So I mean, I guess that's where I'm just how that there's not, is there an analysis of the costs, or and just to see if the prices are if any, there's just any outlier prices, or just trying to understand how that gets dealt with.
So Brian, I see you raised your hand. I don't know if you're going to answer that question, but if not, I'm happy to answer it.
Yeah, I mean, I'm sure. I think I understood where Stephanie, you were getting at. So we do not base it off of submitted charges. We base it off of our reimbursement, which is based on our fee schedule, our DRG payments. So it's not based on arbitrary charges that may come in. So hopefully that assuages your fears there.
Okay, no, that is helpful. Okay, thanks.
Okay, are there any other questions?
Eric, I'm just wondering, and I admit I don't know, is this unique to Medicaid to do this consensus process?
With the state, I believe so, yes.
So there aren't any other programs where, there's the joint, like the three departments or agencies come together?
Not that I'm aware of, no.
Interesting. Thanks.
All right, I think that concludes my presentation. Thanks for the time.
Thanks for that overview. That was really helpful. Great. Well, we are amazingly ahead of schedule. So the next agenda item is an update on enrollment and expansion, which I can't even remember if we did it in January now. Did we not get it to it January? So great. Thanks, Jeff and Maurice. Take it away. And thanks for being here.
Great. Thank you so much. It's good to be back with you. And we are way ahead of schedule, which is awesome. So Sharon, if you'd be so kind to pull up the trends. Thank you so much. This was included in the minutes or the email that you got for the meeting, I hope. If not, please let me know. We can get this out to you as well. So one thing to note right out the gate is that Medicaid this month, and we'll probably say this again next month, is at the highest enrollment that it has ever been in the state of Utah, with 469,447 people, which is pretty amazing. If you think back just a few years ago, when even I thought we would never hit 300,000, and here we are. So with that said, the first graph you're seeing, if you'll scroll down just a little bit, shows the blue, the blue line, which shows the history of Medicaid for the past about 5 years, and with a green line showing CHIP and a red line showing PCN, the PCN program that ended several years ago. I can say that now too. You're seeing that CHIP has continued with its ever so slight of a decline over the past, actually the last 2 years. During the COVID period, it has really had a fairly steady decrease, with one large bump as we stopped holding CHIP cases open. A lot of those children have moved on to Medicaid, and you'll see that in the blue line there as the Medicaid has truly increased. The drivers for enrollment are clearly in the adult expansion area and in the children group, which is not a surprise. Medicaid covers, I think we can still say about half those on Medicaid are children, but more and more we are adding adults each and every month to the program. And that's what's driving that line, of course. Added to that is the fact that during the COVID period, the last 2 years, we have not been able to reduce enrollment in the Medicaid program. We've kept everyone that comes in the door stays with us until the public health emergency ends. So that means that everybody that shows up new, this is truly new growth coming in, because everyone stays where they were, with a very few exceptions of those that move out of states. If you'll scroll up just a little bit, we'll break this out the Medicaid group out a bit more into 4 groups. Sorry, the graph is up, down, scroll down maybe. It's the second graph. Sorry, Sharon. The purple line, there we go. This one really breaks out where you can see that the enrollment for people with disabilities and for those that are aged have really stayed fairly consistent. The pregnant women line, the bottom line, the red one, shows some decline, and that's really finally occurred once we were able to start sorting people in different buckets, if you will, in the Medicaid program. So while we're keeping you on Medicaid, it is permissible to move some people around within the Medicaid program. At first, we're keeping every pregnant woman on the pregnant woman program, regardless of whether or not they'd had the child or the birth or the pregnancy had ended. And that's hyperinflated that number slightly. So those folks are still with us on Medicaid, but now they'll be appropriately put into a different bucket, likely into the adults group in this graph. So again, you can see that great jump there. The first jump in the purple graph that's almost straight up was when we added the initial group to the adult population, and then where it starts to increase greatly again there in April, it was in the March-April timeframe of 2020, you really see the adult group start to take off, and it's been a steady climb since. And then the final graph, which is at the bottom, so that's scrolling down. Okay. Is the group of children. So you can see that the children's growth has been, again, you can see that change. So the most interesting recent point on the graph there on the tail end is from that same time period, March or April of 2020, when we again started to keep cases open. And that has led the children to continue to climb. And it's not climbing at the same rate as the adult group right now overall. I mean, it looks like that graph might be starting to even out, but only time will tell us if that's truly the case. But that's, again, because the cases have been kept open during this period. Again, so children and adults clearly driving the graph and the increase in Medicaid. And at 469,000 people, if what we see holds true, we should expect that to be about 75,000 next month. So record high numbers in Medicaid. Any questions on those numbers or any concerns, questions?
Jeff, just to clarify, so for the pregnant women or for the pregnant category, everyone is moving over, or I guess, how are you determining how to move people without losing people?
Right. It depends is the answer. I love that answer. But typically what we like to do is we put you onto the program that is the right one if we can. So some pregnant women now with an increase in the household size and maybe their income has gone down, will move to the parent caretaker relative population. So that certainly occurs. Some will move on to the adult population, and that certainly occurs. And some will get pregnant again and return to the pregnant woman population. So we see all of those things occur. The majority, I would say, are moving to the adult population overall, but there are some that move to the parent caretaker for sure. And then let me turn a little bit of time over to Maris from DWS, if that's okay. I don't know if you had anything to say specifically.
Yeah, just along with what you were saying in terms of record numbers of Medicaid enrollment. That's exactly what we're seeing. Our caseloads are higher than they have ever been. And then in preparation for PHE ending, we're trying to really remain fully staffed and perhaps even overstaffed and put plans in place to bring some folks that have not worked for us for a couple of years. So we currently are training a group of new individuals that will start working on cases in the next couple of weeks. We're planning another group of being brought over, as many as we can hire. In the Blanding, Richfield, St. George area. That training will start for us on the 16th of May. Hopefully they'll be fully trained and ready to take cases in July, which is when we expect the PHE to end as well. And then on top of that, we're reaching out to some of our recent retirees to see if they're interested in coming back and temporarily work for us. We have identified 11 so far that'll be joining our ranks. In order to staff up for the workload that's coming our way.
And if I could also mention that we are in the midst of a public campaign to try and enroll more children in both the CHIP and the Medicaid programs. And there's some funny moments over the courses of the weeks, but just yesterday I was talking to DWS and one of them asked me, hey, are you guys doing something? Which clearly indicates that they're seeing an uptick in applications, which is wonderful to hear, that we're able to find some children that maybe have not been covered during this last period of time. And that's starting to have some impact to DWS, at least in the increased phone calls, certainly in some applications. So we hope to be able to report in the next several months to show some increase there as well due to that campaign.
Well, that new group, how will the PHE unwinding affect the new group of kids that are coming out? That's really great to hear, by the way. That's exciting about the campaign.
You know, it'll be interesting to see how it affects them. It depends on when they come in. If someone were to show up today as a new child that we've not seen before, they would get Medicaid coverage, of course, or CHIP. If it's Medicaid coverage, they'll actually be now caught essentially into the keeping your case open fully. It depends on how long the public health emergency would end. Typically, we're going to set a renewal for 12 months out, and that's probably what happens to that case. They'll probably be reviewed in 12 months. If the PHE were to go longer than 12 months, we'd keep the case open potentially beyond that. Or if there's a change that occurs that would make them ineligible, they would still remain on Medicaid for the Medicaid children. For those in CHIP, CHIP has a 12-month continuous, as you know. So they would those same changes wouldn't impact the CHIP child for 12 months either. So likely they would come on and experience a 12-month stay with us. Again, that could possibly change if the PHE were to end before the 12-month period for the Medicaid child. And they had a change in circumstances, at which point we would look at CHIP and possibly send them on to the exchange.
Thanks.
Any other questions about enrollment or where we are? Stephanie?
Yes, thank you for the updates and appreciate the work both departments are doing with this increase of numbers. And I know I've asked this before, so sorry, I just can't remember. How much do we know data-wise about, so when there is this increase in enrollment, what is the, how can we kind of learn about like the access to primary care and like the access to just like, some of the just traditional healthcare services? How quickly do we get information about whether or not there is, like if it is just like seeing a quick uptake to like utilization, particularly around like primary and just kind of some traditional healthcare services?
So I'm not the best one to answer that question. Is there someone else with Medicaid that could answer how fast people are seeking services once they become eligible? I mean, I could.
This is Brian Roach. So this doesn't quite get to your question, but part of the way there. So I mean, just recently we did start trying to prioritize into the unwinding plan how recently an individual did access services and make that a factor. There's still some internal discussion about that, but we are trying to take that into account for the redeterminations that will happen during unwinding. But could I make sure I understand your question? Are you asking whether individuals kept on the program are accessing services after their scheduled review date, or help me understand your question a little bit more?
Yeah, thanks for that information. I guess it could maybe break into two separate questions. I would be interested to know just like people that are remaining enrolled past their review date, like, what is their, are they continually utilizing healthcare? But I'm also interested in like the new enrollees and about how quickly are they accessing healthcare services as well? So maybe it would be two separate questions.
And any healthcare services of interest or specifically primary care?
I mean, any, but if it could be broken down into primary care, but if just any general healthcare, I'm just curious what the relationship is between like when they enroll and how quickly they're accessing healthcare.
Okay.
It's a good question, Stephanie. Oh, sorry. Go ahead.
Yeah, I think we can get something ready for next time we meet. Yeah.
Thank you. And then to the whole part, Brian, about this being a part of the ending of the I can't remember what you called it, but like that being factored in, is it being factored in the way of like those who are utilizing healthcare regularly are like like how are you differentiating that between those who are remaining enrolled but they are not accessing healthcare regularly?
I can take this one a little bit. So we are still developing and I'm going to call these buckets. It's not the best term, it's the one we've got. We are going to be allowed 12 months to review everybody in the state of Utah that receives Medicaid. So we have some that's happening with already today. We have another group of people that's around 140, that's an older number now, but about 140,000 individuals, roughly 80,000 cases that we need to also break up across that 12-month period. And that's the group you're talking about. We have to come up with a methodology for how we pick up a case. Which one do you pick up first? So we're trying to use the best data we have, which is imperfect, and some of the points that Brian just mentioned. So a couple of the factors we've looked at. Well, first of all, taking this group, identifying who they are, we've done that, so we can give you those larger numbers. And then we take into account how long someone has been held open. So someone that was held open, let's say starting in March of 2020 or April of 2020 until now, versus someone that started 3 or 4 months ago that's being held open. We would look at that one that's been held open longer first. So we've weighted that to some degree. We've paired that with some utilization data to try and score that a little bit, which would be those that are not using the benefits or not utilizing for whatever reason. That would give them a little bit higher score and then bring them up to the front of the line, if that makes any sense. So we have to look at all of them, but it makes some sense to try and look at those we think that either are not using the benefit or that may have certainly had a change, so we can get that person sorted to the right place, whether that's simply moving a child from Medicaid to CHIP, or maybe it's moving a child to the exchange, or it's possible that they've graduated beyond coverage in both cases. I would think that most of the folks that we look at either will stay where the choices are stay where you are, or find another Medicaid or CHIP program with the state, move on to the exchange. And hopefully there's not too many that fall in the bucket of we couldn't find you, or you didn't follow up with us. So does that help at least try to understand? And I guess the other piece that we should factor in, because it's a complicated thing, is that there's some people we think we should push to the front of the line, and others we think we should push to the end of the line. So pushing to the end of the line, we anticipate pushing those that are covered by emergency services, because whether they apply before or after, there are other protections in place to make sure that we're not paying for anything that's inappropriate above and beyond the emergency. That should reduce some applications for DWS over the course of the 12 months of unwinding. That seemed to make some sense. And then also, if we are aware that your case is, for example, over income, and we know you're going to move, we just don't know where, based on the most recent information we have for you, that'll push you to the front of the line. It doesn't mean that necessarily you'll move. It means that we'll look at your case first and see if you, again, qualify for the same program, move on to another state-offered program, or onto the exchange. So it's complicated, and we hope to share a lot more detail about that, I believe, in the next MAC next month.
Yep. And Stephanie, I just wanted to add one more thing. So to your question on how quickly people are utilizing services, one complicating factor is that under federal regs, providers have 12 months to submit the bills. So somebody might be utilizing services immediately, but we may not know about it for several months. And so that's a complicating factor. Usually we have a pretty good picture of what's happening within 6 months. But just to caveat that we won't know immediately, and we really won't know and won't have that full picture for 12 months until after they've been on the program for 12 months. And so that adds a wrinkle to the question you asked to Brian, but it also adds a wrinkle to what Jeff was proposing of how we're determining those people and determining what order to put them in as far as the review.
Okay, that's all really helpful. Yeah, I look forward to hearing more next month if you all are able to present about that, and then any data that you're able to present too, Brian. But anyways, thank you so much for spending some time on that. I appreciate it.
You bet.
Jeff, just kind of, or to Merce, just as a kind of primer for what we're going to talk about next month, can you remind me, so if somebody is moving on to the exchange, how does that happen?
We have a process built in today. It's called account transfer, and it's funny, depending on who you talk to, the federal government will say there are accounts coming in and those going out to the state. We call it just the reverse because that makes it more convenient, right? It's funny how these things work out. But we do, if we look at somebody on Medicaid, again, this is in normal times outside of the current public health emergency. But if we were to look at somebody and determine that they're over income and no longer eligible for a program with the state, we simply bundle up that package of information and electronically send the file over to the health exchange, at which point the health exchange will determine whether or not they qualify for subsidies or whatever programs are available there. And the reverse is also true. You can go to, back in the day it was called No Wrong Door. I would argue that there are better doors. One could choose a better door, but if you went through the federal marketplace first and started there, and let's say that you truly would qualify in the state of Utah based on our federal poverty limit levels that are set in our state, the exchange will refer you to us. And that also comes in through this account transfer. So it's an electronic interface between us and the feds. It communicates daily. We do a really good job with that overall. I think, and Merce can give better stats on that if you care to, but we actually do track which cases come back and forth. Sometimes the case that comes to us from the federal government already has applied at the state. They've gone through both doors, in which case they're already maybe eligible and we're moving on that path already. But we do have that ability to exchange cases back and forth to the exchange. That's funny, to send them back and forth. And that works very, very well in our state. Merce, would you add anything? I'm sorry.
No, just Jesse, so you're aware, this has been an automated process both ways since the launch of ACA. So we've had this going for a very long time. It has been smooth. It is something that we seek certification on and have to update in order to receive this information from CMS. The other thing that maybe should be mentioned, during the times of open enrollment, what we see is a large uptick in cases that we see that are coming to the state. But regularly on an average month, we receive roughly about 2,000 cases from the exchange and send about 1,000 their way.
And when you send them your way, it's funny that I think this will help when we talk next time. Is there some on our end, they come to to DWS, they come to caseworkers. Is there, what does it look like on the other end? And thanks for, I know this is a little bit off topic, but thanks for just.
No, it's okay. And Jeff kind of started talking about that. Once a decision is made on the case, if it's an approval, then there's nothing additional needs to happen. In case there's a denial, the system automatically checks the type of denial it is. And then if it's something that we need to be sending to the exchange, we bundle it up and send it in that daily exchange or the daily batch to FFM.
And Jesse, to that I'd add that, and this question came up as we talked to health plans not too long ago. I think there's a common misunderstanding out there that if there's a paperwork issue, let's say that either a form wasn't turned in, and so we don't truly know that the person's ineligible, or something was just never turned in, whatever that is. If it's a paperwork type of issue, those cases don't get sent to the exchange. We only send people to the exchange when we know truly that they don't qualify for our programs. So it's not like you come in the door and everybody will see both places. They'll only see the exchange from our perspective if they truly don't qualify for a program, or if they're, so, and Maris mentioned denial, but it's also closures as we review cases. And so over the next 12 months, once the PHE ends, it's going to be, as the cases close, we'll be making that determination. Was it a paperwork error? Meaning that we can't do anything with that. The case would simply close, and that person would be, not receiving services from us and not being referred to the exchange. Or was it in fact someone that we know was not eligible and therefore they move on? And this is why it's so important that people do complete that renewal with DWS. If the choice is, well, I don't think I qualify anymore, so I just won't do that renewal, then they never get that second opportunity to move to the exchange. So it's important that we actually do look at the case and make sure that we get them in the right place.
Thanks. And I know that there's been some ongoing conversation about maybe even trying to get a little bit more granular around if somebody doesn't come, because I imagine, what we're probably going to talk about in the coming months as the PHE unwinds is where are those points where people get lost, and the more granular we can get to help people through those points, or to, find those, that probably helps too for you all. Like, are there places where people get especially stuck, or paperwork that, seems especially hard to track down during the renewal process? So maybe that's something too we can just even talk about next month a little bit.
There's just one caution I would put to that. The federal exchange does require a Medicaid decision in order to consider eligibility for the exchange itself. So if we are not looking at closure reasons and not making that determinations, those folks will be sent back to Medicaid for determination. So I think it makes sense to what Jeff was talking about, is let's complete those reviews as much as we can, and let's make those determinations, because that will be something that the exchange asks for.
Great, thank you.
Thanks so much. Back to you, I guess, Jesse.
Thanks. Any other questions, or anybody else? Okay. All right, well, look forward to hearing more. Thank you both for sharing all that. That's really helpful. Great. All right, well, I am just floored. It makes me feel like maybe I'm not asking enough questions, so I'll hold back. Jed, the time is yours to give the director's report.
Yeah, thank you. And we're going to start first with the ARPA funds update, and Eric will present that portion, and then I'll cover the policy spas and rules. So thank you, Jesse.
So unfortunately, I apologize. I don't have a formal presentation other than just to speak to what's happening with ARPA funds. So basically, as a reminder for everybody what this funding is and where it came from, with the passage of ARPA, the federal government is allowing us to draw an additional 10% federal funds on certain services, so specifically home and community-based services and what they call rehabilitative services. Now, because of the way our state plan is structured, that would include behavioral health and school-based services. So we are able to draw that additional 10% matching funds from the period of April 1st, 2021 through March 31st of 2022. So we're still in that period of what I like to call drawing down the funding and establishing what our pool of funding will look like. So the easy way to kind of conceptualize this in your mind is to think, typically we get about $70 for every $100 we spend from the federal government. With this additional funding, that would take it up to 80. Now, one of the conditions of this additional funding is we cannot supplant general funds. So in other words, we can't use the federal funds and reduce the state's investment into these programs. So this money that we get in additional federal funds needs to be offset by more investment into these programs. So based on this, we've ran some rough numbers, and what we're seeing so far, we're pretty close to on track of what we think that pool will look like. By the end of March 31st, we're anticipating having about $72 million in that pool of funding that we need to reinvest into these specific programs. And we have a whole list of items that we're doing to reinvest these funds. So one of which was a 5% supplemental payment to these provider groups. And the idea there was to provide an immediate relief to them with their staffing issues. And so we have started and are in the process of making those payments, those supplemental payments to these providers on a quarterly basis. That so far is the only item on our list of items that CMS has fully approved. We have a whole, like I said, a whole bunch of other items that have yet to be approved by CMS, and we're still working with them on that. Tanya, it looks like you've got a comment.
Yeah, I think, Eric, just a slight clarification. I think CMS has generally approved those other items. Unfortunately, CMS's communication on approval is not really clear. But we have several other items that we feel confident that we can use savings that Eric just described. We won't be able to draw down additional federal funds for those, but with the savings achieved through that, the 10% that we've been able to draw down from CMS, we do have other projects that we are in the process of just figuring out how to roll out. The one specific project that CMS did not approve was using these funds for payment of family caregiver compensation, and we've addressed that through other means. That was we received an appropriation for that at least one time through the end of fiscal year 2023. But we'll maybe at some point in the future, Jen, we can come back and talk about those remaining projects and kind of where we are in terms of implementation.
Yep, thanks, Tanya.
Thanks.
Yep. So at this point, like Tanya mentioned, we are making those 5% supplementals and continue to work through some of the difficulties there. One of which is being able to provide reconciliations to the providers to kind of explain, okay, here's a breakdown of what made up that supplemental payment. And so given that this was rolled out very quickly by CMS, it didn't give us a lot of lead time to build this process out and have it ironed out and have all the kinks worked out. So it's kind of been a learn as you go process, and we've been working through it. So any questions on the ARPA funds?
Eric, did you see the question from Stephanie in the chat?
I did not. Let me pull up the chat. Sorry.
It just said, what provider groups will receive this?
Oh, okay. So it'll be home and community-based service providers, behavioral health providers, and school-based providers.
Can you specify, and this is as for me with the school-based providers, what does that will be through this? Well, can you provide more clarification about what school-based providers?
So we call it the School-Based Skills Development Program, and these are services that are actually performed in the schools for Medicaid eligible children.
Right now, that just is for students with an IEP.
Yes, they have to have an IEP. That is one of the requirements.
If over the course of this time, while these, if we were to allow additional services to be rendered in schools for students that don't have an IEP, would this also apply?
It would, but it might strain our budget a little bit. And the reason why is we base that budget off of what we could draw down through March 31st. And so if we expand the scope of services, then it puts us in a situation of, we were planning on paying 5% on that base funding. And now if you add additional services, we don't know that we have the budget to continue paying 5% based on that additional new service. Emma?
Yeah, I was going to comment that I suspect, Eric, that the behavioral health services that are being provided in the school setting are probably getting picked up in the behavioral health provider list, because they're largely being provided by the local authorities anyhow. But any provider who is billing Medicaid, even if they're providing that service in the school, would be getting picked up in this data pool.
Thanks for that clarification, Emma. Okay, any other questions? Okay.
Eric, if you are able to share, I know we're asking for a lot of, but if you have the list, I feel like in the past you've shared what the plans are for this beyond the payments. If that's something when it's ready to share it, that'd be helpful too, I think, or we could do it at a future meeting.
Yeah. I mean, yeah, we can certainly share the list of what the items we're looking at funding are.
Mhm.
Yeah, we're happy to do that.
Okay, and then I'll transition over to some updates around policies, spas, and rules. We do not have any spas to present this month, but we do have 3 rules that were sent out with the agenda. Sharon, would you mind just clicking on the rule tab there just so we can see 2 of these items? The Medicaid policy for experimental, investigational, or unproven medical practices is a 5-year review, and there were no changes to this rule. It is our standard process to have these reviewed every 5 years and submitted for public comment. And so this was a 5-year review on this particular policy. The second policy that went through a 5-year review was eligibility for home and community-based services waivers, which looks specifically at the eligibility requirements for the home and community-based service waivers. So there were no changes to these rules. Are there any questions on these particular rules? Okay, and then the third rule that was submitted this month and is in the March bulletin is our adult expansion modification, which removes the work requirement from the adult expansion rule. You'll see that language is stricken from the existing rule and has been removed. As you scroll down here, it's contained in the content in the packet. So are there any questions about this rule update? Okay, Rachel, I'm seeing there's language about sanctioning folks who fail to register for employer-sponsored health insurance. How would that work? Okay,
Jen?
Jeff? Yeah,
Sure.
that'd be great, Jeff, if you could help with that.
So back when this bill passed for the adult expansion, some may recall, and perhaps some do not, there were 2 items in there. One was the work requirement, which this removes. There is no longer a work requirement for Medicaid, and that's what this rule is about. The language on sanctioning is that there was a second piece that said that if somebody had access to employer-sponsored health insurance, which we, for no great reason, call ESI, employer-sponsored insurance, if someone has access to that insurance and fails to enroll in that insurance, they can be sanctioned, which means removed from the Medicaid program. So the good news is that if someone has access and they enroll in that insurance, we can help pay for it. So we actually buy the health insurance for them, and we work through that process as we identify someone that's on the adult expansion program specifically and has that access. But if they choose to not enroll for whatever reason, they would lose their Medicaid coverage as well. And that's what that sanction is referring to.
Thank you, Jeff. Did that answer your question, Rachel?
It does, thank you.
Yeah, you're welcome. And thanks for the help there, Jeff.
You bet.
Okay, if there are no other questions on the rule updates, I'll move to a few policy updates we'd like to share with you. The first policy update is actually going to be put in place on July 1st, but there's much work in this area right now, and it's around our Utah Transit Authority contract. And so the change that's happening, this work is being done between Medicaid as well as DWS for individuals who receive a UTA pass for their transportation benefit. This is currently a paper pass that is managed through DWS. UTA is ending their paper pass process that's been in existence with Medicaid for many years, and they're eliminating that and transitioning to a digital tap card process. And so this is a pretty large effort that many of us at Medicaid as well as DWS are working on, and it will have definitely a transition on the Medicaid membership and something that they're used to. There are about 15,000 passes issued monthly now. And so there is a project plan that's in place with all the stakeholders that are working on transitioning this process. We're also going to be moving the process of that card distribution. The idea right now, a member gets a monthly paper card with 12 punch passes in it. And if a member is also has an attendant that is authorized to ride along with them, that would be indicated on the paper punch pass card. This new process actually gives a digital card, which is meant to be held by the members. So month to month, they would just keep this same card, and the passes themselves would be renewed monthly as that individual maintained eligibility and needed to continue with UTA services. So the process is shifting just a little bit, but the idea would be that we'd be able to much better track exactly who's using their cards, the attendant giving them a separate card so that they could ride along as a parent with their child, or as an individual who needs attendant services, they can accompany them with that. But this work is moving into the Medicaid group. So DWS will no longer be issuing the cards. It will be managed through the Medicaid division. Are there questions that any of you have about the UTA process and that policy change? Stephanie.
Yes, so I just want to make sure that I understand. I know this, I think this has come up previously, but so this will be beyond the bus pass, because it is going to open it up to the tracks and the front runner as well. Is that?
It will encompass the UTA services, yes. Along, yes.
And then that data that you're collecting, so will we be able to see we'll be able to see like how much UTA utilization happens? And great. Yeah, this is really, really great.
Yeah, we're actually looking forward to that piece, Stephanie, because right now it's hard to know what's being used when it's a paper punch card. And during COVID, the drivers weren't really wanting to punch the passes. And so it's been hard for us to assess utilization. So with this, we'll be able to look at utilization. And we are, our policy is going to continue allowing 12 rides per month. And what this means is that those are one-way rides in each direction. It would be, 12 one-way rides essentially, but there's also an opportunity to request more rides for individuals who may need extra services for a month or two, and they're seeing their providers more frequently. They have the opportunity to request additional cards to be added, or rides to be added to their card. So.
That's great. And what is that process to request more? Is it similar to the one that exists currently?
What this will do is it will run the request through, there's two options. One will be through the My Benefits portal, where the member can actually go in and request a card themselves. So if they want a card for the very first time, our communication strategy will encourage the member to get into the My Benefits portal and go through. There's like a 2 or 3 question survey that screens the individual for, living within the Wasatch Front and not having access to a vehicle. So we'll ask them those screening questions, but it will also allow them to ask for a replacement card, and it will also allow for extra rides. The other option is to be able to call in through our HPRs, so through our health program representatives, and speak to one of our staff and request it through that process as well.
Awesome. This is great. Thanks so much for the update.
Yep, you're welcome. Was there
And
another question? Yeah.
Jen, this is Jeff. Just one clarification. I believe that the pass that we're proposing only covers tracks and the bus system. It does not cover front runners. What I'm
Not
hearing.
front runner. Sorry, Jeff. Thank you for the
Sorry about that.
clarification.
Okay, cool. And do you know why not the front runner?
I believe it's a cost issue. That's what I understand. Sorry, if that helps.
Yeah, we could clarify that, Stephanie.
Okay, yeah, I'd be interested to know why,
Okay.
but that's great. Thank you.
Okay. You're welcome. The effective date of the change will be July 1st. We will be sending out member communication. There's already a notice going out to providers in this month's Medicaid information bulletin. So we'll be doing a provider education as well as member education. And that will start going out with the Medicaid paper cards, the UTA paper cards. There'll be a stuffer with that. Jeff, you're on this working group. So that's one item. I believe that's starting in May.
Yes, for the June cards, really, we send out in May. We'll be giving the first stuffer there, and then a second one again for the June cards that really won't be going, right? So it's the 2 months before. So in May and June, you'll get a stuffer to let you know what the process will be to get a new card. And to Leah's question there, the effective date of the change is July 1st. So the switchover actually occurs. Hopefully we get people coming to us in June to get their new bus pass issued, and they should be using the new pass as of July 1st. The paper passes will no longer function as of July 1st.
Thank you. And then Maurice, I believe your team is supporting this effort through phone calls as well. Do you want to speak to that, please?
Yes, we currently handle, and maybe just one other clarification as we talk about this. This change will affect the majority of the users of the public transportation system. Like Jen said, this change is effective for UTA only. There are several other entities in the state of Utah that participate in the public transportation. Those folks are not affected by this change. So if you're using something else other than UTA in the state of Utah, the paper application will process. The paper pass will continue for you if you're not on UTA. So as far as us supporting that process, we're actually educating our staff, and we're removing the ability to request a pass from the system in our June build effective July 1. So somebody that might be requesting a pass from us will no longer be able to do so after July 1.
Thank you, Maurice.
Yep.
Any other questions about this UTA update?
Jen, this was just a clarification. So is this are all Medicaid members eligible for the passes right now if they request them, or are they, which groups? Oh, thanks, Jeff shaking his head.
Go ahead, Jeff.
Yeah, oh, sorry, just natural reaction. So sorry. This is for the non-traditional package does not receive the bus pass. Everybody else can.
Okay, so parents can't essentially, or parents and caregivers.
Most parents that are on that program, I mean, you can be a parent and be an adult, disabled, right? So there are a lot of different groups there. So adults, disabled, child, all those groups can get a bus pass if they want one. The only one that cannot is if you're on the parent caretaker program specifically.
And they have to be requested, right? They're not like will that change now with the card? Like, will the card be able to go out, like the plastic, the card go out even if it's not filled, kind of thing?
We're asking. We do have and this is part of the process, Jesse. I want to make sure that we communicate clearly the process by which we identify the original membership who is getting the existing bus passes. And that's a very large volume of individuals, right? And I believe we're still talking through whether that needs to be a request only process or if there will be an original mailing that may address, the ridership we're seeing today. And we can bring that back to you when we determine the pathway we're going to take on whether it will be an auto mailing first time or if it will be by request only because of our workload as well and managing the requests as they come in and making sure people have them. So that's part of our working group, is that discussion of looking at those pieces. But I think it's a good question. Thank you. Okay, we can bring updates as we move forward with this process. We can bring you updates on, you know, any changes or new information that we have, as well as communication that we have put out for both members and providers on this update. So when we can share it with you and have you look at it as well. So another update I wanted to share, it's a minor detail around our telehealth policy, but it was an enhancement in the reporting. Right now in our telehealth services, we have a place of service O2 that indicates that the service was delivered, but it was delivered as through a telehealth modality. There was a new indicator that was released called Point of Sale 10. And what this specifies is that the telehealth service was delivered in a patient's home. And so we are activating that to go live. We'd received a couple questions about whether or not we were applying that, and we have put that forth in our policy, and that is going live. The next effort that I just wanted to touch on, while we've spoken a lot about the PHE unwinding from an eligibility perspective, and Jeff and his team with DWS as well have done a great job on working on those efforts, there's another aspect of around that surrounds our provisions for policy changes and service delivery that have impacted both providers as well as members. And there's efforts around unwinding or what these services are going to look like. So many of these provisions were outlined in our emergency spas and our disaster recovery spas, as well as our 1135 waivers. And we are doing a comprehensive evaluation of what was approved, what we actually put in place, and then what we are actually going to maintain and keep in place, and versus transition and turn off at the end of the PHE. So a couple of examples that we'll bring up of policy work that we are evaluating are, for example, drugs and tests that were approved under emergency use authorization. So COVID treatments, vaccinations, and even some over-the-counter tests or other COVID tests that are not fully FDA approved. These have been, some of them fully federally funded and administered underneath the EUA or an emergency use authorization as the public health emergency ends. And that draws to an end. We need to look at our coverage of both drugs and tests for COVID. So that's one example. Another example is, as I mentioned, our telehealth services. We've certainly expanded these in important areas around behavioral health services, for example. We've loosened our geographic restrictions that we had originally in place for ABA services for autism. And some of these, again, we also, one important one to know is our telephonic services, so audio only provisions that were put in place. These are important things that we're looking at and evaluating as we prepare for the end of the PHE, what the impact it will have on some of our policies and the changes we put in place as well for those. So there will be comprehensive work done and already is a good bit of comprehensive work done in this area, but there will also be communication that will come forth around what these services are and how and if they will be changed at the end of the PHE. So yes, Andrew.
Thanks, Jen. Just a question: is there going to be opportunity to provide input or feedback on any of the things that you guys are thinking about doing before you make the final decision?
Andrew, we always take your feedback and input, so certainly you can pass that through the committee here and move it through our executive committee so that we can receive that, or you can send that to me directly. We're happy to hear your input and feedback.
Do you have a preliminary list that you're working from so that we can have an idea what you're thinking about and provide specific and useful feedback to you on it?
Certainly, we can certainly look. Some of the provisions that were put in place are on our Medicaid COVID-19 website, and those have specific member, there's a member portal, there's a provider portal, and there are some things identified there. We also have some internal working documents that really identify unique things, and we can certainly get something like that available in a more of a summary form so that you can see some of the provisions we've put in place.
Great. That would really be helpful for us and hopefully useful for you all. So
yeah, thank you.
Thank you for bringing this forward.
Yeah, you're welcome, and thank you for your interest in giving your recommendations as well. Sheila?
Hey, Jen, I was just curious, is there any work that's going to be done on like outcomes data for the telehealth services that have been delivered on the behavioral health side? I've been really curious about this. I've heard some anecdotal things about, better follow-up to behavioral health, like post-discharge visits and things, but I'll be really curious. Are you guys going to be collecting that kind of data?
Yeah, I'm not as familiar with exactly what we're looking at, Sheila and Brian. Or others who are on this call who have been evaluating some of the use of our telehealth metrics. Sheila, some of that data is not well reported around telehealth services. I know that we feel utilization may be better than what's actually reported. But if I could, I don't know if Emma, ask others to participate or contribute to the response here.
Yeah, Jen, I think we've heard anecdotally too from the prepaid mental health plans that they have really found the telephonic only telehealth to be very beneficial, not only due to the pandemic, but they've indicated that they have been able to engage people in treatment who would never walk through their doors. So maybe if we reached out to them, they may be able to provide some more specific information.
Yeah, thank you, Emma.
Thanks, Emma. Thanks, Jen.
Yep, you're welcome. And Brian?
Yeah, I can just add as well. So I am aware that with the follow-up measures, I think you were mentioning, Sheila, the telehealth or telephone visit would count as a successful outcome. But it is not separately broken out as an outcome measure in that. So it would count as success for us, but no numbers right off the bat there. Yeah.
Thank you.
Thank you. Are there other questions?
And for the telehealth code you mentioned before and the changes to that, can you just clarify that one more time? Does that mean that like the home can be a site, or what does that mean?
Yeah, and then yes, it's specifically looking at the telehealth services provided in the patient's home. Okay, that summarizes some of the policy and rule updates we wanted to share for today. So thank you.
Great. Is that it for your report? Great. Awesome. All right. Well, one thing I just wanted to mention briefly, I forgot to at the beginning of this meeting, is that this came up a few meetings ago, probably our January meeting, we talked about putting together a flyer for new or interested Medicaid members. That flyer is in the works. Thank you to everybody that's been working on that, and we will be able to share that out soon. And maybe we can just spend a little bit of time at our next meeting during the committee member updates around how best to get that flyer out, or if there's any ideas around distribution there. But just wanted to give an update on that and appreciate the thought and time that's gone into that flyer. It's looking great. And that's it on my end. Are there any other questions or things that people would like to raise before we close unusually early for this meeting? Which is a great thing. Hope everybody can enjoy the rest of your day. But are there any other final questions or comments? Okay, great. Well, thank you, everybody. Hope you have a wonderful rest of your afternoon, and we'll see you same Google Meet place next April or in April. Thanks so much, everybody. Bye.
Thank you. Bye.
Bye.